Okay, welcome everyone to our webinar series. If you haven't already done so, I see people still typing in the chat bar, so please include your email address if you would like a copy of the presentation today. We're going to have a presentation that's about 15 minutes, and I'll put in the chat 5-minute warnings so that we can keep on track and that we have enough time for questions at the end of the 15-minute presentation. Please you can type your questions in the chat box at any time, or at the end of the presentation, unmute your phone to ask a question. This webinar is being recorded and will be posted on our website, which is listed here. For a review, the CCIM4C is the Community Collective Impact Model for Change initiative, funded under the federal 21st Century Cures Act as part of Ohio's state-targeted response to the opioid crisis. Ohio MOPS awarded funding to 12 Ohio communities to address opioid use and misuse in their communities by combining a strategic planning process with an emphasis on working across the continuum of care while utilizing a trauma-informed approach. We also partnered with Ohio University and the Pacific Institute for Research and Evaluation, as well as Prevention Institute, to develop training and technical assistance for our communities. But we're also holding the webinars and training materials with open access on our website here at the bottom so that we can help prevent opioid use and abuse, reduce opioid-related deaths, and increase access to treatment across the state of Ohio. This webinar series aims to bring together all the field experiences, successes, and challenges to offer any kind of wisdom to other communities that are facing similar issues or challenges, as well as broaden our knowledge base for the communities funded under CCIM4C. We wanted to provide additional resources, strategies, and content to these communities and the state of Ohio as a whole, working so that everyone working at the local, state, and national level can address opioid use and misuse. So today's webinar is being brought to us by Steve Snyder-Hill, and he's going to talk about harm reduction basics. And with that, I will pass it over to you, Steve.
Okay, thank you. Can everybody hear me okay, hopefully? I'm on a speakerphone, so I just want to make sure it sounds all right.
You're coming in clear for me.
Okay, great. Okay, so thank you for giving me this time to kind of talk about some initiatives that we are doing here at Columbus Public Health in Franklin County around harm reduction. So basically, I like to put this slide in any presentation we give about harm reduction. I'm probably preaching to the choir, but just to explain, harm reduction is, and what it is, basically that we're trying to reduce harm in daily things that people do. We do that daily. We do that in things like, going the speed limit, or things like, lifting with your legs and not your back, and things like that to reduce harm. And this is really another aspect of that type of harm reduction when we talk about substance use. So basically, we like to talk about addiction when we talk about harm reduction, because one of the things that plagues harm reduction initiatives is stigma. And I mean, it's stigma from law enforcement, it's stigma from the general public. And so we always try to remind people exactly what addiction is before we talk about harm reduction, because harm reduction initiatives a lot of time are met with a lot of stigma. So basically, harm reduction is very important to preservation of life. And we like to say that it's reducing harm and it's meeting people where they're at is the basic premise of any harm reduction program. So opiate addiction, like I said, I'm probably preaching to the choir, but we know that it interferes with a person's ability to rationally consider any kind of risk or reward system. So addiction is a chronic relapsing brain disease, and I'm not going to play the video for you, but the video is basically the old 80s video about, this is your brain on drugs. And it truly does change our brains when we use any kind of substance like an opiate. So it does go through functional and structural changes your brain does. So we like to give examples of some of those changes by an example of our harm reduction manager goes out and talks about somebody being underwater and how your brain starts to make you panic, and it makes you feel like that you need to do something to be able to live or breathe. And a lot of times when somebody's addicted, or they're severely addicted, or they're on, you know, their brains actually start to go through the same types of processes to make their body feel like that if it doesn't have whatever it's got used to, which in this case would be an opiate, but it could be any drug, that they start to panic, and their brain starts to tell them that they're going to die if they don't get that, and it starts to change their decision-making processes and everything that they do, and their, you know, the things that we generally judge them for as far as, you know, the moral characters and things that we typically hear when we're talking about addiction. So those changes in brain function and the ability to consider the risk versus the rewards definitely increase the rates of any kind of HPV, so any kind of hepatitis or accidental overdoses, or the things that we're trying to reduce when we're talking about harm reduction. So a lot of the times when we judge people or think that they shouldn't make the decisions they make, we're judging from a totally different perspective of somebody that's not had their brain altered, you know, that chemistry altered. So we like to throw this thing in just to show that there are structural changes, kind of like if you're going through some kind of a physical surgery, how your bones would be impacted if you fall down and you know, that you've gotten some kind of a device implanted to try to make it better or whatever. That it's basically the same types of things that you're doing long-term changes of your physiological structure of your brain. So it's just like a physiological structure of a bone or anything else. We don't like to think of it too differently from that, because it is really important to understand that this is a physiological change. And this just kind of illustrates the need for the recovery and how long it takes to recover, and that it isn't an overnight process. So again, this stuff is really, really basic. It's preaching to the choir, because we all know that that is the premise of addiction. The reason, like I said, that we add that to this is because harm reduction, there's a lot of stigma around it. We're going to talk about that, especially when we talk about some initiatives that we've done locally here. Because it impacts brain functioning for an extended period of time, those harm reduction programs that we're going to talk about, some of the initiatives we've done, are very, very important to try to keep people safe until they're ready to seek treatment. But if you go to really hardcore harm reduction seminars or conferences, people will really kind of lash back on you and tell you that, you know what, if a harm reduction program, the function of that should not be trying to get somebody to seek treatment. It should be to just reduce their harm daily, and not to try to put them in a place that they're not ready to be in, which is, you know, a premise of trauma-informed care, that you let somebody dictate their own, you know, ability to recover. And so we're trying to reduce harm to give them the ability to work on their own schedule, so they don't get hepatitis, and they don't get HIV, and they don't overdose, and get one more day to live to be able to dictate how well they'll be able to receive treatment. So it's basically the premise of meeting someone where we're at. And that can be several things. That could be physically. That could be that we want to be out in the community where they are. That could be that we're meeting them where they're at, meaning that we're just making sure that when they're ready to seek treatment, they're you know, we're going to have treatment ready for them. Or that, you know, the only thing that they can do today is to get a clean needle, so that way they can continue to get well, as some people call it, when they inject heroin, because they feel sick if they don't. So it's the equivalent of you or I being, you know, having the flu. Some of these people that inject heroin daily to go to work, to function as a regular adult, do it just so that, you know, they can feel well for the day. And some people refer to it like that. So we're trying to make sure that they're able to do that without, you know, spreading hepatitis or getting a co-infection, and being able to function the best they can until they're ready to seek treatment, and keep them alive another day until they can get that treatment. So harm reduction can be defined as any program that targets the population of the individuals who are actively misusing or addicted to a substance, and that's intended to reduce the risk of harm associated with their substance use to themselves or to the community. And again, I'm just trying to illustrate all that. So now let's talk about the core of this. So what are some of the initiatives that we do here in Franklin County around harm reduction? And we have a ton of them that are going on. So the big one that you hear about continually is the access to naloxone. So we basically want to make sure that we get naloxone out to the community and that everybody carries it. We started with a NEOP event, which was basically a naloxone education and outreach program. We started going out into the community and giving that naloxone out to community members that might have somebody that in their family has substance use disorder that, that they have that available, so that way if they need it to help somebody in the event that they would overdose. Then the harm reduction manager here at Columbus Public Health really wanted to start micro-targeting our outreach efforts with naloxone and decided that we want to get it out into the community where people need it the most. So we did a NESOP program, which was a street outreach. So we started going out to homeless encampments and trying to get naloxone out to people right out in the community and not where somebody will have to go to get it. So we would go out into the community and meet them where they're at, which is one of my core principles of harm reduction. So we started to do both of those types of events where we're getting the naloxone out to community members as well as naloxone out to the actual community itself of people that are inflicted with substance use disorder. We do a ton of overdose prevention education to the community. We have a DIS team here that is in our treatment program that's housed right within the health department, which is pretty unique. I don't know that all health departments hold their own treatment program. Generally a referral service, but we actually house the actual treatment right on site here with counselors, starting MAT soon. But the DIS team that's located here within Alcohol and Drug Services actually goes out into the recovery community and to the active addiction and using community to test for HIV, HCV, STIs in general, and give education. That was a really powerful experience when I went out with that team and listened to them talk, because it's something that you and I just don't think about, that team is really specialized in what they do. So they aren't just going out and testing, they're actually going out, and when they talk to people, before they actually will test them for HIV, they'll ask, is this going to be a trigger to you? So, if somebody injects heroin, just the feeling of a needle going in their arm can trigger them to want to use. So that team is really inept, that they're basically well-versed in knowing exactly what to say to people and to make sure that they're doing the correct things before they would test somebody to make sure they aren't causing any harm to them. We do a lot of data tracking here, and we're tracking overdoses. We have a program basically that feeds live data in that we can look and see what the overdoses are in the community. And at the health department level, we can track that down pretty tight. For the community, we have to, because of HIPAA and privacy concerns, we have to kind of generally keep the data a little bit less specific, so you can't narrow down to know that your neighbor overdosed or to track it down that close. But basically, we track that quite a bit, and EMS runs and ED department data. So we watch that type of data. We have a lot of advocacy efforts here around harm reduction and trying to talk about harm reduction like we're doing today. We have the syringe exchange program, which is referred to here in Columbus as Safe Point, and it actually used to be a syringe service program, and due to some of the community concerns, we did change it to an exchange model this year. And again, we can talk about that a little bit more when we get to Safe Point. AOD consultation, referral for treatment, recovery support, we do those. We do community safe syringe safety and disposal campaigns, because with any harm reduction program where you're giving out clean needles, you're bound to see more needles in the public as far as if people aren't, just getting rid of them properly. So we have to talk about mitigation efforts if we do see increased needles in the community. So we do a lot of those types of cleanups. And below, I think that I'd say also that we have the needle disposal boxes that we engage in. We have medication take-backs. So those are any part of a harm reduction program. Safe disposal of medication is important. And we also integrate sharps take-backs into our medication take-back days. So I think that that's a really, really great addition to a normal drug take-back if you do it, you know, twice a year with the regular community, that you can take back sharps as well. Gives people a good opportunity to be able to get rid of sharps. We have a lot of community conversations. And we've collaborated with our neighborhood health division to be able to go out into communities. Particularly right now, we're going out and doing a lot in the African American community here in Columbus, because there is a lot of misconception that this is not affecting the African American community, when it really is, because a lot of the fentanyl that we're seeing now is not being found in things that people typically think that they find them in. It's being found in meth and coke and things that the African American community are, you know, using, and just have no awareness that they have to worry about overdosing that way. You know, so carrying naloxone is extremely important, and getting that education out to the community is very important to know that the overdoses that we're seeing, increasing numbers of, are, you know, in drugs that typically we wouldn't think that would contain fentanyl. And then speaking of fentanyl, we have the test strips that we give out called Project Life, which is limiting involuntary fentanyl exposure here at Columbus Public Health, and we're very, very proud of that initiative. And again, that actually was born out of conversations about the African American community, where we wanted to get a tool out to the community for people that recreationally use. That just, you know, they're thinking about maybe they're going out and partying on a weekend, and they don't at all think that they can overdose or die from that, or that fentanyl could be in their product. So that's a really important part of the fentanyl test strips. We have Project SIN, and that is something that was born because here at the health department we do an overdose surge notification process, where if any number of criteria trigger a surge, then any number of our partners can, you know, initiate this call where we all get on and we'll talk about. Oh, Tracy. I'm sorry. So we'll basically initiate a surge call that we'll be able to talk about what we're seeing and try to talk as a group about what we can do to be able to get public messaging out. Or like we've done with Project Send, is we've gone out into the community directly where the zip codes of the overdoses were occurring, and got people out on the street giving them not only naloxone but fentanyl test strips. So those are a couple of the initiatives that we've been involved in as well. And then we have a service entity naloxone training where different organizations can be trained in being able to use naloxone for their employees, and they can be trained and kind of fall under our guidance here at CPH. So SafePoint, like I said, is the syringe access or a syringe exchange program, excuse me, now it's an exchange model. And this is an example of their website and some of the different services that they provide, which are the overdose prevention, syringe exchanges. They have some primary care that they can do on site, which includes, you know, wound healing, abscesses. They have drug intervention, so they can talk to an AOD counselor. They have STI testing that they can do, and then just help for other linkages to services. Our SafePoint program is expanding, and they're going to have expanded hours, and they're going to be available all week long instead of just a couple times a week. So that's exciting. We're really happy about that. The fentanyl test strips, I've shown you here what they look like. And again, this has been a tremendous, great effort with CPH. And we had to really overcome a lot of stigma with this too, because the first thing that people will do is give you pushback and say, are you enabling? And that's probably the first thing that whenever you're talking harm reduction, people always, the first thing that comes up as a stigma is saying you're enabling people. If you give somebody a needle, you're enabling them to use heroin. If you give somebody a fentanyl test strip, you're enabling them to go out and seek fentanyl. I can tell you when I sat down with SafePoint the first time and walked through with the counselor, and they gave them all those materials. They gave them the needle. They gave them all the materials they need to use drugs. Me, just like everybody else, I looked at that and thought, in my gut, I thought, is this right? Because this person's getting these materials to be able to use, and is that bad or is that good? And as I was sitting there thinking of that, the counselor was talking to them and said, so how's it been with your family? And, the person said on the other end, they said, it's been really bad, I haven't been able to keep a job, and my relationships are bad. And so that person had an interaction with a counselor that they never, ever would have had. That relapsing brain disease is going to make them use. They're going to feel like they're underwater. They're going to feel like that they need it to live. And so they're going to use regardless of any intervention that we're going to give them. But that counselor had the ability that moment to talk to them and just introduce a little bit of compassion and sympathy for them, that they know that somebody cares and they know somebody can talk to them about it. And that's opening the door for someday them being able to receive treatment, whether we know that or not. I mean, they're not going to be able to get that with a drug dealer. They're not going to be able to get that with a primary care physician, which they probably don't even have. They get that little conversation and that interaction we have because we have a captive audience giving them a safe, clean needle so they don't contract or spread hepatitis. So that was when it really was evident to me how important harm reduction was in the Safe Point program, because we would never get that opportunity to be able to talk to that person or to be able to be in their thoughts or open their mind to anything else, or even just give them a friend to be able to talk to. So that's why harm reduction is just so important. So we developed a little educational card about fentanyl test strips. You can kind of see it here. It talks about how to mix the drug and be able to test it. And just an example of this is our harm reduction manager was out, and I think she was at dinner with some friends, and her sister was there, and her sister's little, not her sister, her best friend and her best friend's little sister were eating dinner with them. And her best friend's sister was just a little bit, she was listening to this, and she was like, man, fentanyl is in everything. You've got to be careful. And she was kind of scared a little bit. So later on, our harm reduction manager got a call directly from that sister, and she said, I didn't want to say anything at supper because my sister's there, but I want to tell you that my friends and I were going to do coke this weekend because, that was the recreational thing we were going to do. And now you have me terrified about it. So our harm reduction manager went out with a fentanyl test strip and tested the coke that they were going to do, and it did have fentanyl in it. And that was a huge wake-up call to everybody involved, because even when we get these fentanyl test strips out, we don't realize the power that these can have to avert the use of people that just not knowingly would have used that drug. And if you have active addiction, so say you are a heroin user and you are chemically addicted to it and your brain has, changed the chemistry to make you think that you need it. So what would be your argument to give out a fentanyl test strip to those folks? Because then you could say that part of that stigma is that they're going to seek fentanyl. I can tell you that what we do is we do education with them. We tell them that we know that they're going to use, right? So we want to reduce their harm. So we have the opportunity to educate them and say, if you're going to use and you test and it has fentanyl in it, please microdose. Don't use the same strength that you would normally use because it will kill you. And so it gives you an opportunity to be able to empower them to know how to use acceptably not to die. And I mean, again, you'll have a lot of pushback in the community when you say you're teaching somebody to use acceptably, because what is acceptably used? We don't want them to die. We want them to not do something that would harm themselves, and we want to be able to keep them alive long enough to get treatment. So if that involves us trying to explain to them what microdosing is, then that's what we want to do until they can accept treatment. There have been many people that have been in recovery programs. Some of them are staff members that now have dedicated their lives to helping others, that would tell us, if somebody didn't have that compassion for me at one time, I wouldn't be here today. And so that's really powerful. So the fentanyl test strips, basically you can see that you use them. It comes up like a little bit like a pregnancy test. It'll say whether it's positive or negative. Really, really easy to use, and we have a QR code that goes with that. So if they test, we ask them to answer a couple anonymous questions that basically come back to us and tell us that what they decided if the test was positive for fentanyl, and what they decided to do if they used the drug and microdose or if they just didn't use it, to give us some kind of data so we know what is happening. With the fentanyl test strips,
thank you so much, Steve. I want to make sure that we have time for training or for questions.
Okay.
If there's any way you could go over quickly, or we will be sending the slides out to those who put their email address in the chat box. But I
Okay,
did just want to pause and see if
Yeah.
anyone had questions.
Okay, gotcha.
So if you could unmute and ask questions if you have them, that would be fantastic. And we will send out the slides to anyone that puts their email address in the chat box. So even if there was a little bit of information on the last slide that we didn't get a chance to cover, we will be sending out those slides. So I see some people typing. If you want to unmute though, that could be faster as well.
April, while we're waiting for those other questions, this is Julie Spohn, and I work on our Cures and State Opioid Response Grants at Ohio Mass. And since these calls are part of the Collective Impact webinar series, which is funded by Cures, I just wanted to clarify that the test strips are not an allowable expense of our Cures grant or any CMSO-funded grant. However, we still encourage community members to seek out other funding sources in their communities for fentanyl test strips if this is a strategy they'd like to pursue and to support the overall efforts to reduce overdose deaths. So definitely something we want to support but are unable to use SAMHSA funds for that.
Thank you for letting us know that, Julie. So I don't know that anyone has any questions as of now. I'm not seeing anyone else typing. Thank you for putting your email in the chat boxes. Is there anything else in like 1 minute, Steve, that you would want to wrap up with?
Actually, I think that the rest of the slides are pretty self-explanatory, just to talk about different medication disposal things. One thing I will say is that on this slide about the medication disposal, we teach people to be able to dispose of their medications with kitty litter and just different inexpensive ways. And then we also have the Terra bags that we use and disposal sites. So I think that, I'm sorry, I definitely went long-winded on the fentanyl test strips, but there are a lot of initiatives you can do when it comes to regard of harm reduction in your community. And hopefully we touched on a bunch of those today.
Yes, thank you so much, and thank you for putting up your contact information here. If people have questions after the webinar, is it acceptable to contact you?
Yeah, absolutely.
Okay, thank you so much. So thanks to everyone who put their email in the chat box. If you want to receive the slides, please do that. We will post a recording of this webinar to our website at collectiveimpact.mha.ohio.gov. Thank you so much, Steve, for presenting today. You gave us a lot of information, and thank you, Julie, for letting us know about the test strips. And our webinar series will be resuming in January. We're taking a holiday break, so we will send out more information on the next webinar soon. Thank you all for joining us, and have a good holiday.